100 though?
I'm good for always, any 50 question test, I'm good to miss at least one. So everybody turn around, look in the back. It's my spawn. Hi! Just bring your daughter to work today? Every day, yeah. She just wanted to come in. She keeps asking me, what do you actually do? I don't know. Not much, apparently. But what does a PA do? So I brought her in to see, what did we watch yesterday? Oh, the mock OSCE. I was like, that should answer some of your questions. A little bit? All right. All right, review, and then we'll go downstairs after, and you guys can get some reps in. So remember, just in case you forgot, so you'll take your 50 question test, and then you'll go downstairs, essentially draw a card, right? So I'll print out one of each. I actually printed out 20 of each, but the instructors will take one of each and probably let you choose, not seeing what you're choosing, but just like, hey, pick a card, any card, right? I actually didn't care when I was grading them. I'm like, which one do you want? Like, please don't give me neuro. And I'm like, why? It's so much fun. Whatever they decide to do, and then you guys will do that and you'll be done. So this will be another 50 meter target in the rearview mirror. So before we get started with this, so there's 51 slides. Why 51? Yeah, so I went through and looked at the exam, and yeah, I'm just going to be honest with you guys. So all the blue box answer slides, I just pulled them, and then I added one because I'm like, I got to be mysterious and let them think I'm at least not giving them. They say I can't give you 50 things to know. That's what they told me. Like, you can't just tell them 50 things to know. So I was like, what about 51? They didn't say not 51, so. Yes, so for this will be the review. I'll send this to you after this, and then you can distro it out. Is that fair? So y'all don't have to take pictures and think it's like you're getting over on me. I'm just going to give it to you guys. Like, you can have it, don't worry. Like, hold on, let me take a picture here. Yeah, my disclaimer, I got to do this. So yes, for optimal success, study all the material. It's only going to make you better. If you study this, just this, will you pass? Yeah, absolutely. Will you get 100? I don't know. Maybe not. It depends on how you conceptualize material. This test isn't designed to be hard. I don't know what you guys heard from the class ahead of you. So we were there yesterday. That was the mock OSCE, and I was like, what did you guys tell them about the exam? Oh, it's an easy 50 points, whatever. Like, and then I found out that their lab time, they didn't even have to show up. So I don't know if you guys knew this. I did not know that. It was optional for them to even show up to do labs. So you're welcome for all that extra practice you guys get. You're just better than them. There are clinical questions in there. Absolutely, because we're starting to move away from the rote memorization stuff. Don't change your answer. The day of the test, I'm not giving you guys a pep talk. This is why I'm saying this all right now. So I come in, like I say, hey, good morning, guys. Like, let's get it. It's kicking in the teeth, right? I'm not going to sit there and try to get in your heads because you have your own routine of how you do things, and I don't think it's worth changing. But don't change your answers. There's studies out there that say that usually your gut is right, and we change them to the wrong answers. Anybody change their answers? I still do it. It sucks. I hate it. I wish I could stop, but I can't. It's like crack, right? Whatever that feels like. My patients tell me. And then lastly, so here's the deal with this. So people are taking the test. This one always baffles me. You guys have probably realized that I'm going to make mistakes. I'm human, just like you. If there's a mistake on the test, like, I want you to get that back, right? Just don't start freaking out and being like, yeah, you said this, you said that, right? So someone next to you is still taking the exam, and it's not fair to them, but it also will probably hurt the results, because if they hear that it's messed up and then they adjust fire, and then the statistics come back, because I love the statistics. If it's a question that like a large part of you guys missed, then I just go to test committee and I'm like, yeah, I'm a booger. I taught that terribly. Like, I think we should give it back to them. And they're like, all right, stop being a booger, right? And I'm like, I can't. You're stuck with me. So, but So just don't argue. We can talk about it after the test. We can, come to my office. We can talk about it in the hallway. But just in this room, just respect the left and right limits of the exam itself. So, all right, fair enough. Fair enough. All right. Yeah. So when you examine the tongue, look everywhere, especially the sides. Right. So I'll try to kind of, if I can even remember what the test question was, but. I don't remember the exact scenario for each one. That would be lying to you guys. But just when you do a physical exam on a tongue, make sure you look on the sides, right? Because that's where carcinoma can hide out. So you guys know that because we've been doing it downstairs. We didn't talk too much about oral leukoplakia, but scaly looking, it's pre-malignant. It doesn't scrape off, and you got to rule out squamous cell carcinoma. Okay? You guys seen this before? I don't know what you've had or haven't had in ENT. So you probably just, maybe you're going over now, but there's a question on there. So your Weber and Rene, so just remember when you place it midline, so ask the patient where they hear the sound, right, and how to do this. So you may draw the card downstairs. Just remember normal air conduction is greater than bone conduction, and then with your bone conduction greater than air conduction, that's conductive loss, okay? So just remember the difference between these, how we do it, because you may actually have to demonstrate it, and then what is a concerning finding? I think there's, oh yeah, here it is. This might be the 51st slide that I added there, because I was like, oh, that's good too. So for your conductive hearing loss, that second bullet down, right, sound lateralizes towards the affected ear versus your neurosensory hearing loss or sensory neural hearing loss. Lateralizes to the normal ear. So just remember those. I'll take a look at that. Septal hematoma. So in a facial trauma, we got to rule this out, specifically with the nose, right? So buildup of blood on the septum, and it can cause kind of necrosis of that septum. So that's why we're looking up the nose and making sure there's no bulging of blood to the septum. And those pictures in the bottom, that's just showing you that septum being destroyed over time. So that dude's nose he's got a septal hematoma on the left side and a rockin' mustache, dude. So, okay. Cheilitis. So again, it's kind of like a skin changes. You can get angular cheilitis, which is on the sides of the mouth, or cheilitis all around the mouth, typically from licking or it's from drying and scaling, right? Just take a look at that. Consider biopsy when standard treatments are not effective, right, to rule out cancer, just because those are sun exposed areas. Good. PTAs, peritonsillar abscess, so uvula deviation, one side swelling, right? Muffled voice, you guys see all there. So severe throat pain, fever, irritability, hot potato, or muffled voice. I don't know why the potato got the burn, but they sound like they got something, or they're eating something, right? Sitting, leaning forward, drooling, trismus, right? They got some pain there, and then some neck pain and swelling. So you look in, you see that uvula displacement. Just be kind of familiar with what a PTA is, okay? These are actually fun to train. Yeah, have you guys taught PTAs in ENT? Yeah, what do they say about draining? I'm just curious. Be very careful, right? So I think emergency medicine journals just published like the chance of hitting like an artery is real low. I mean, I'd probably be the one person to do it, but you will call, so some of the smaller ones I won't go after, sub-centimeter, but if they're big and angry and the person's like a struggle bus, like you gotta go ahead and get it. And then you see that bottom picture with that syringe full of purulent fluid. Do you think it's usually that clean and nice when that happens? No, it's usually like my first like puncture with that 18 gauge, like doesn't do anything, and I'm like, oh god, I airballed this, and then I move a little bit medially, and then I hit it, and now there's pus like all in their mouth, and they're like, ugh, and they start vomiting, and I'm like, you made it, dude, it's your problem. But, I think I told you guys, or maybe I didn't. I had a young lady who her throat just looked atrocious, but she was diagnosed with strep. She was on clindamycin 3 times a day, like day 7, and came in, and I did a CT of her neck, soft tissue, and she had bilateral PTAs, which I hadn't seen before. I'm like, you got 2 of them, and they were like 2 centimeters, so I got to dart both of them. But ENT was like freaking out on me because they're like, you should never drain 2 of them. And I'm like, too late, man. Like, we already did it. It was so fun the first time. And she felt great. We was just worried about like residual bleeding and or obstruction of the airway. So I just went in quietly. I was like, man, can you just kind of lean forward into this basin and not aspirate that? It's just good sport. So. All right, abnormal otitis externa, so be familiar with that, right? External auditory canal infection, right? Acute bacteria most common, ear pain, discharge, right? Usually from swimming, submersion underwater, or Q-tip usage. So what do we tell our patients about using Q-tips? Don't use them? How many of y'all use Q-tips? You son of a guns. Yeah, why? Why do you guys use them? Oh, man. Well, then listen, lie to your patients and tell them you don't, right? So now don't lie to you, ever lie to your patients, but you're right, I do too. Like, I got nothing. It does, it's like a guilty pleasure. It's such a bad thing. But remember, we're just pushing that cerumen back in and we're causing that impaction. And then I can't tell you how many times I've come in with the ER, which is patients that perf their TM. Has anybody done that with a Q-tip? Nobody wants to admit it, right? Oh, everybody's like, yeah, I use Q-tips, but nobody's perfed it. All right, just wait, just wait. All right. So take a look at otitis externa, how it presents. Oral candidiasis, right? So usually asymptomatic. This can be scraped off, unlike what did we talk about before that can be scraped off? All together now. Leukoplakia, good. So, and if we see this on a patient, what are we concerned about? I mean, it says it on there. Yeah, like something's hampering their immune system, right? It shouldn't be like this. So things you might want to consider testing them for. Yeah, sure. AIDS, yeah, some other thing that could be compromising their immune system, but HIV is a good one. So good. All right, thyroid examination. So we didn't go over too much about this, but just how to do it. So remember a methodology. So I don't know if you guys have practiced this downstairs, right? I hadn't been walking around too much on this one, but inform your patients, like let them know that you're going, hey, I'm going to examine your thyroid. I'm going to put, so like go behind somebody and put your hands on their neck. Like what's your initial thought? Like I've seen this movie before, I know how it ends, right? Like someone's going to get all like Kung Fu, BJJ and follow you up, but you don't need all that trash, right? Like, hey, I'm going to feel your thyroid. I even tell my patients, like, I'm not choking you out, I promise. And then I pretend, like, not I don't do that. But, have them swallow, right? So you can use, it says out there, tilt their head backwards, use tangential lighting. So, like, look, listen, and feel type deal. And have them swallow. And we're feeling for nodules, any pain, discomfort, asymmetry type of thing, okay? Xanthal asthma. So yellowish, swallow, circumscribed, cholesterol-filled plaques on eyes. Anybody seen these in some of the zombies walking around San Antonio? Yeah. Yeah, it's like the cholesterol and the Whataburger in their blood is screaming so loud that it's bursting through their eyes. So it's pretty neat. Or they might just have a congenital problem. I'm just being a jerk. But you see this and like that should like be a concern for like a cholesterol issue with this person, right? So. If anybody has this and I just called you out, I apologize. Like that's incredibly rude, really insensitive. Like, I'll probably have these in a couple of years if I keep working hard on them. So. All right, let me see. Pinguecula versus pterygium. So I would know the difference between the two. So remember, pinguecula, elastic tissue, but it does not extend into the cornea, and then your pterygium does, right? So this could be encroaching on their vision. So. And typically, your ophthalmologist can remove these. They're pretty neat. You guys will probably scrub in on some of this and just sit there. Don't touch anything. Don't breathe on it. They just kind of peel this off. Sometimes it comes back. Sometimes it scars down. So somebody has these in here, right? Someone was showing these off like one of the labs. I don't remember who it was, and I'm like, yeah, it's neat. No, wasn't you guys? All right. I'm gonna go look at eyes now. So, all right, your strabismus, your alignment of eyes. Take a look at your tropias and your phorias, right? So, know the difference between them. So, right, your tropia is always there, whereas your euphoria is occurring some of the time. Okay, take a look at your cranial nerve 6 paralysis. Okay, so cranial nerve 6, your abducens paralysis, right? And how it's going to present. And remember, this is going to be like the blue box answer, so I don't remember the question, that's why I'm saying that. I think it's like, how does it present, and then there's probably some pictures of crazy eyes, and you can snuff it out or something, but ton of pictures on the exam, like, I don't know. I think it makes it easier, but that's what we'll keep them. So, conjunctivitis, so presentation of conjunctivitis, so this is just showing you normal, bacterial versus viral and allergic, right? Giving you a little bit of pearl for each one, but just looking at injection of the conjunctiva, either one or both eyes. Okay, you can see there with your bacterial, you're going to have that sticky yellowish green discharge. You know, then your viral and allergic, right? So you think you're allergic, or is usually going to be bilateral or unilateral? It's probably bilateral, right? So the irritant is probably aggravating both your eyes. And then depending on how you guys decide to treat this or what your EMT instructor says, I treat them with antibiotics, like all of them. That's not the right answer. Whoa, time out. Unless I know for sure it's allergic conjunctivitis, but these people cannot stop itching their eyes, and then they just get bacteria from their fingernails into their eyes, and they develop a bacterial conjunctivitis. So. But if you're EMT, if Captain Hansen's teaching you different, don't answer it and then say, oh, it's my fault, right? Just tell me how I need things done. All right, your cover, uncover test. So be familiar with that. Okay, cover one eye, watch the uncovered eye for movement. Uncovered eye moves, there's a tropia of that eye. If it moves outward, then it's an esotropia. If it moves upward, it's a hypotropia. Okay, you guys got all that. Retinal lesions, so retinal hemorrhaging. You look at the back of the eye and you see kind of like bloody spots back there. You can be concerned for what? What do you guys think? I know it says it on the slide, but just think about it, right? So if you're walking around, your blood pressure is like 220 over 110 constantly, and you're just causing pressure on those little arteries that are arterioles in the eye, you're going to burst them, right? That's a bad sign. That's a end organ damage sign, which is, with that patient, I just gave you a hypertensive emergency. All right, periorbital versus orbital cellulitis. It's kind of easy money, right? So periorbital is a cellulitis around the eye, whereas a orbital cellulitis is going back, penetrating into that cone. You guys know the eye is kind of a cone with those muscles, and there's only so much room to swell. So if you have an orbital cellulitis, that's a bad deal. We need to admit those folks with IV antibiotics, whereas a periorbital cellulitis, you can probably treat them outpatient. What's the big, how do I delineate the difference between the two? Do you guys remember?
Eye pain?
Yeah, pain with extraocular movements, right? So that'd be concerning. What'd you say? Same thing?
I said eye pain.
Yeah, eye pain. All right, subconj hemorrhage, or bleeding underneath the conjunctiva, right? This could be secondary to a cough, a sneeze, just increasing your ICP. Maybe they had a large bowel movement, they were an elderly patient, I see it all the time. They're coming in and thinking they're dying, so you know, this is gonna heal like a bruise, eventually go away. If it doesn't, then you'd be concerned for something else. You can see there it can be caused by choking, coughing, straining, or vomiting. Hyphema, blood in the anterior chamber, right? Usually secondary to trauma. So you guys look at your patient, you kind of see like a blood liquid level in the eye, right? So we need to check that out further. That's very concerning. So Argyle-Robinson, or what's the other name? Do y'all remember? Nobody? Okay. So Argyle-Robinson, we'll just leave it at that. So no constriction to light, wrist constriction to near target, right? So neurosyphilis, anybody remember now? So somebody wants to say the word prostitute, like everybody's like, oh, I'm not saying it, you say it, right? So that's what kind of got me through this phase one, is like putting stupid things together, being like, all right, Argyle-Robinson was a prostitute, right? They reacted but didn't, or they accommodated but never reacted, and they had neurosyphilis. I'm like, I don't know why that sticks with me, but whatever you got to do to make it work. So All right, JVP, I think every single person downstairs is like, am I ever gonna do this? I've never done it personally, but yes, it's in the Bates manual, so how are we gonna do this and what are we looking at? So basically a step. A clinical bedside way to look at what? Right heart, right, good, right heart function, okay, good. And then take a look at it, right? So what did we say normal was? You guys remember normal measurement? Like 6 to 8, I don't know, 25, 48, like 70. It's not bingo, guys. Like 6 to 8, right? So good. Because remember, we're going to add that 5 for that anatomical 5 centimeters for that anatomical deviant to get to the heart itself. So deviate. That's not the right word. You know what I mean, damn it. All right. So, and if you draw this, right, definitely, if you draw like the heart, like, please do this. Like, don't be like, oh, Roger said don't have to do this. Like, you're going to want to do this, right? This is going to be one of those ones where you're like, I'm going to get to do this at least once, and here's my time to shine. So, does everybody remember how to do this? Okay, good. We can practice it downstairs. We're just going over these now. So, extra hard sounds, so I'll go a little bit quick on these, but physiological S2 splitting, right? So this could be normal. Take a deep breath can exaggerate it. So best heard in the pulmonic region between the second and third intercostal space, left sternal border. Take a look at aortic valve stenosis. So some of your etiologies, rheumatic valve disease, and then it's accentuated in patients sitting and leaning forward. So since we're doing clinical skills, it's probably going to be something like how do you accentuate, or what physical exam maneuver can you do to best hear aortic valve stenosis, and you would choose sitting and leaning forward. That's it, okay? PMI, what it is, right? So point of max intensity. So you guys are all, when you're downstairs, feeling that left side, kind of feeling the points of the apical point of the left ventricle, right? So can be displaced from LVH or left ventricular hypertrophy. Really, they're either secondary to volume or pressure overloaded. So just know when you're evaluating how you do or how you estimate PMI. It's really through field and or tangential lighting. You guys can kind of see it kind of pulsatile. So easy 2 points, preload and afterload. So definition questions, just take a look at it. Like I don't know. I can't sit up here and tell you how to memorize this stuff, but like there's a question on there with like, which is the load that stretches cardiac muscle before contraction, right? And you're like, it's going to be preload 10 times out of 10. So just look at that and afterload as well. S3, extra hard sound, and ventricular gallop. So take a look at your S3 sound, S4 sound, question on one of each. Aortic regurgitation, okay. Sitting, leaning forward with breath held after exhalation. So that Corrigan's or water hammer pulse. Anybody remember that one? Okay, it's kind of that upward, kind of like rolling pulse in the neck that kind of slams down, but that could be concerning for aortic regurg. Holcomb, hypertrophic cardiomyopathy. So that's the obstruction of the septum there, right? So slow over time. That septum gets thickened, and then what happens to our patient when they're running suicides during basketball practice? They die. They go into cardiac arrest, right? So it's like, basketball season, when it kicks off, you'll hear on the news, like, usually local news will carry it, because they don't carry Holcomb nationally, but they'll say, like, oh, young basketball player, dropped dead. Everybody wants to say immediately, like, cocaine, right? Like, they did cocaine. Maybe they did, I don't know. It probably made it worse, but I think Holcomb, what's the other one? Like young football players they'll fall all the time. It can be Holcomb, but usually it's dehydration and poor conditioning. And then combatives. This has nothing to do. Tangent. I'm going off on a tangent, by the way, but you'll probably talk about it in cardiology. But like combatives, baseball, like your catchers sometimes will take a ball in the chest. Football, we saw DeMar Hamlin from the Bills. This happened to him, but commotio cordis. Have you guys heard of that one? So you get hit so hard in the chest that it disrupts the electrical conductivity of the heart, and then you go into cardiac arrest. That's what happened. It was the Bills. It happened on national TV. So does anybody remember watching that? Yeah, I was watching that, and I was like, dude, that's commotio cordis like 10 times out of 10. And they never said it was, but I think it's pretty easy. But catchers will go to catch the ball and just miss it, and it hits them right in the chest, and then they're down. So that's why I started putting like AEDs on little league fields to save people's lives. So, yeah, all that mildly interesting. It's really irrelevant to your exam, so I'll just keep moving forward. So, sorry. Pneumonia. There's a question on pneumonia. So take a look at this slide. So what does a patient look like when they come in with pneumonia? I don't know, fever, chills, plus or minus productive cough, shortness of breath. Does that sound good? I'll probably make them have like green sputum for you just to mail it home. You guys listen and you hear what? You're like, adventitious breath sounds, right? That's what I say. I don't know what they were, but they sounded abnormal to me. Crackles, bronchi. So this is a parenchymal infection of the lung tissue. So bacteria get warm, dark, moist areas, reproduce and cough, and they have byproduct of purulent discharge, right? In those alveoli sacs, if you have that, remember that's why you guys are doing all this like egophony, whispered pectoliloquy, tactile fremitus, is we're all looking at how sound travels over fluid versus air. So, okay. Pectus excavatum, let's take a look at this. So depression of the lower sternum, right, sunken in, can cause complications, decreased exercise tolerance, tachycardia, palpitations, murmurs, chest pain. And you guys can see that, this is not a cartoon picture, but the written picture, and see that compression of the heart and why that's causing those complications. So, bless you. You gotta let that out, though. Yeah, it's gonna backfire one of these days. So, wow, I stumped myself. What is this here for?
Sounds.
I know what it is. Thanks, man. There's sounds, yeah. Yeah, thanks, man. No, I'm like, but what is the question I'm gonna ask? That's what I'm trying to say. Yeah, oh, these are sounds. You guys want to take a look at these? I can't remember the exact question, which is kind of bothering me, to be honest with you. But when you're percussing, kind of take a look at the different sounds and how they present. So more to follow. Maybe I'll go back and send this when I forward it to you. Like, see how I'm feeling, but because I'll go and look just to make sure I'm not losing my mind. But, all right, take a look at Kussmaul breathing, air hunger, right? So this is that really fast, deep short breathing. So shallow breathing, you're going to see these, and we kind of talked a little bit about it. I think I tried to show a video, and I think it didn't show at that time, but DKA patients will come in with Kussmaul breathing, right? Breathing really fast. Why are they doing that? So they're acidotic and they're trying to get rid of some of that, right? It's not working for them. That's a late compensatory mechanism, and that's bad, right? My kids usually do this. My type 1 kids that come in the ER and DKA are Kussmaul breathing, I know it's going to be a long encounter. I'm like, damn, that sucks for you. But I'll usually either intubate them pretty quickly, sedate them, intubate them, get a central line and start working on swinging them around. Don't know that I've ever seen my adult population Kussmaul breathe, but okay. And then Shan-Stokes breathing is that near-death breathing. So remember, you have that your brainstem is going to be responsible for your respiratory drive. So these folks are breathing, right? And then there's a long apneic pause. This is usually when you have everybody at bedside saying bye to grandma, right? And they're like, oh, she's so good. And then all of a sudden, out of nowhere, takes a deep breath, and they're like, she's alive, like, save her. And you're like, nah, dude, it's not alive. It's not. And they're like, we changed our mind, our DNR is now revive her. And you're like, son of a gun, like, this is awful. But anyways, it happens. So you can take a look at the videos. Bronchitis, inflammation of the bronchial tubes, leading to increased mucus secretions, right? Usually due to an infection, mostly viral, right? fever, chest pain, usually pleuritic chest pain. When they take a deep breath, it's going to bother them. It can be dry or productive coughs. Take a look at bronchitis. And then what do we do with bronchitis? You guys, have you talked about, we haven't had pulmonology yet, so I don't know why these are thrown in here then. It's really not fair. So, I would just look at the physical presentation of. I'm not going to ask you treatment questions, but for chronic or acute bronchitis secondary to a viral infection, like Tylenol, Motrin, drink water, change your socks, pull security, like all that good stuff. You're not. They're like, I need azithromycin. Like you don't. But like 8 out of 10 providers will give it to them just because they're like, I don't want to listen to you. So not the right answer. All right. This is just showing you chronic bronchitis or COPD. So chronic bronchitis actually has multiple flavors, right? There's COPD and then there's emphysema, but we'll just look at COPD in itself. Tactile fremitus, physical exam. Practice it downstairs, why we're doing it, how to do it, right? Good. Some more on tactile fremitus. Don't care what you say. Blue balloons, 99, boy oh boy, something cooler if you want to come up with it, but increased tactile fremitus and pneumonias, right? So I'd probably look at the radiograph right there is right. That's showing you a right middle lobe pneumonia. So just kind of taking a look at that and seeing that, obviously we see the radiographic changes on that, but why is it different, right? Because it's that sound traveling over the fluid versus the air above and below it. So cool. Stridor, so high-pitched piercing sound, often heard with inspiration. You guys can see there, right? Can't miss this. This could be associated with epiglottitis, which that patient's going to lose their airway, as well as an aspirated foreign body and/or croup. But this is a bad sign, especially in your kiddos. Oh, and there you cannot hear anything, so you're welcome. I don't know why, but we'll just listen to it after I send it to you. So just get that. I have no way of putting that sound on your exam, so but I would take a listen to it. So when you hear it, you're like, oh no, that's not a good sign at all. So take a look at your obstructive versus restrictive patterns, right? So there's different kind of like patterns. I know this isn't pathology, but this I think will help you a little bit. So, this is broken down. So your obstructive pathology, COPD, emphysema, asthma, chronic bronchitis. What the problem is, you can see there. Characterize. Don't worry about the FEV1. That's like your PFT findings. We're not going to worry too much about that. And then how you manage it. So, I think there's a question on there, kind of delineating between a restrictive or obstructive. So just take a look at that. Obturator sign. How to do it, what it's doing, okay? Gray Turner's and colon sign, right? What is it concerning for? Okay, gives you some examples up there, but just take a look at those. Bruising in the umbilicus and the flank. Yes, it could be trauma, but it could be something else too. SOA sign. How to do it, what it's doing. What is it a pertinent positive of the patient with an acute belly? Cholecystitis, how it presents. So you guys remember the test we kind of look at for cholecystitis? Yeah. Are you asking me a question, my daughter? Where's the bathroom? You're stopped class to ask for the bathroom? Yeah, go out the door, take a right, down the hall, take a left, you'll find it. Good luck. Yeah, so Murphy sign is what I was saying. So push down, have the patient take a deep breath, and then what's positive? Right, they stop breathing and they like hit your hand away, right? No, they don't have to hit your hand away, but the sensation of breathing, so. Okay. Epigastric hernia, small midline protrusion through a defect in the linea alba between the xiphoid and umbilicus, right? So just kind of know that definition. There's a question on there about that. Abdominal bruise, right? Blowing or swishing sound, right? So a bruit is a basically turbulent blood flow, okay? Auscultating with the bell of the stethoscope, excuse me. All right, pyelonephritis, right? Physical exam wise, it's concern for pyelo. Really CVA tenderness, right? So they may just have, pyelo essentially is UTI is an ascending infection, but it has upper GU involvement. So if you have CVA tenderness, you can consider it pyelo. So these folks are usually ill appearing and sick, fever, all that good stuff. Maybe they're meeting your SEERS or systemic inflammatory response criteria, which we're not going to talk about, but fever, tachycardic, leukocytosis, all that good stuff. Rossing sign, so palpating the left lower quadrant, kind of pulling on that peritoneum, causing that irritation, right? So this could be concerning for an appendicitis, okay? And well, why? If I'm pushing on the left, does it hurt on the right? Because you're stretching that peritoneum, okay? Rebound tenderness, you're looking for peritoneal inflammation as well, pushing down, letting go. When you let go, you get a sharp stabbing pain on the side with peritoneal inflammation, right? Okay? Too easy. Fair? You're like, I don't know, I'll tell you on Tuesday after the exam, right? Take a look at those. That's what I extrapolated from the exam, blue box. But like I said, I hope you guys, who am I kidding? When I was in your seat, I was like, just tell me what I need to know for this exam, man. But this is what you're going to be doing. So I guess I'll try to appeal to that part of you. This is your job. Like, this is what you're going to be doing. So aside from memorizing it and then dumping it, you guys will call upon this in Clin Core 1, Clin Core 2, or junior, so whatever we call it. And then every day, therefore, when you go out and do your job. So this is what you're paying the big bucks for. This is what you're going to get paid both, right? So this is what you're going to be doing. So figure it out. Now's the time to do it. Cool. Downstairs, take a 10-minute break, go down, and we'll kind of, is that the right time back there? It should be. Yeah, we'll go down, we'll start downstairs at 10 o'clock. I have